Welcome to you all, and thank you for being part of the Royal Society for Public Health's Sparks Debates webinar series. I'm Kamlesh Patel. I've been lucky to be associated with the Royal Society for Public Health for somewhere around the past 8 years, and currently have the honour of being its president. As many of you will know, that the Royal Society is an independent health education charity and the world's oldest public health body. Our vision is that every community, workplace and individual should have the opportunity to optimise their own health and well-being. So today's webinar, the future of public health systems, is absolutely key to how that vision is delivered. And, look, I'd love to be with you all in person. We probably wouldn't get as many people in a physical room, but what a year it's been, what a year we've all been through. I don't think I'll ever forget 2020. I'm sure a lot more won't. A year that's brought a real sharp focus for the need for transformational change in health and social care systems. And a year that certainly has shone a very, very bright light on the continuing health inequalities we face. So in the short time we've got available today, our panel will cover a number of key issues in respect of future public health systems. We're going to be looking at health inequalities, how to improve outcomes, building effective and strong workforce and public health systems, and hopefully highlight some future opportunities that are planned reforms might bring. Not unsurprisingly, this has been an extremely popular webinar. We've got over 500 people registered, and we're fortunate to have such an esteemed and experienced panel today. I've already received a whole raft of questions that have been sent in and that are continuing to come. But please, I can't get through all of them. We won't have hours to get through them, but don't stop sending the questions and maybe even comments. Use the chat facility, because at least we'll be able to capture some of that and it'll inform our future work. And just to inform you all, today's webinar is being recorded and we intend to share it with all those people that have registered. But that's, look, enough from me. Let's listen to the real experts. And we've got 3 great speakers today. First, I'd love to introduce Professor Maggie Ray. Amongst her many responsibilities, Maggie is currently the president of the Faculty of Public Health. She's got a presentation and she's going to cover a few key points, namely the delivery agenda for health inequalities, which I'm really interested to hear, how do you improve public health outcomes and building an effective public health workforce. Maggie, over to you.
Thank you so much, Lord Patel, and a real joy to be with you today, colleagues, and I'm a very proud fellow of RSPH, so it's especially a privilege to be at this webinar today. As Lord Patel says, I've been given a brief for today and I'm going to concentrate on 4 themes. So Zoe, if you don't mind, could you share the slides, please? Thank you. Thank you very much indeed. If we could just go straight into the first slide, please, Zoe, thank you. So as I say, it's a real pleasure to be here today, and this is a short presentation because I think the really interesting bit will be when we get a chance to discuss these issues, and we've got some great questions. So thank you very much to those who've already submitted questions. I think the future of public health systems really need to be all about health inequalities. The audience that we've got today know only too well that as a UK, we are not in a good place with health inequalities. The pre-pandemic information about the stalling life expectancy for the first time since records began, that is a shocking situation to be in, and we're very grateful to Michael Marmot for actually raising awareness in his excellent report. But we really have to concentrate on these health inequalities, and the whole of the public health system, and all systems really, way beyond public health, have to be focusing on this. We did see some excellent reports during the pandemic, including the report from Public Health England that raised awareness. but we really now need to look at who's been affected most by the pandemic. And interestingly, there's a very strong correlation all through this to the simple matter of poverty. Poverty causes ill health, and this has been shown right through history, and it's now been impacted even more by the pandemic. So really the future for me of the public health system needs to really concentrate on these important issues, and we really have to make addressing the inequalities central to our public health post-recovery, post-COVID-19. Next slide, please. And how do we do that? Well, we have to focus more on health outcomes. I think there's a real opportunity coming our direction, particularly in England and in all 4 countries of the UK, to really have the opportunity to recover in a different way and try and focus more on the public health outcomes. I think the great wisdom I learned in my career, particularly when I was leading on health inequalities for the Department of Health, of course, it was a simple message. But when I realised that I discovered the wisdom that most public health interventions actually widen health inequalities. We can all go around with our interventions expecting to do good, but unless they're targeted to the right populations, the populations most in need, applying general interventions actually by their actions widen health inequalities. So we need to be much, much more targeted as to where the health outcomes are worse, and probably do much more on trying to shift the agenda in the lower deprived, in the deprivation areas, and to try really get more resources in there. I think as I say, most of this is driven by diseases of poverty, and that's where we really need to focus our attention. But of course, the whole of the country has been deeply affected by COVID, and there are pockets of deprivation everywhere. I know Chris Whitty, the CMO, is planning to release his report on the health and well-being of coastal towns. And again, you'll see the deprivation there in his report. So we have pockets everywhere, but we have to focus on those particular areas. And a big part of a public health system, a good public health system, is really focusing on the needs of their population and really having an opportunity, I think, for trying to get more prevention into the NHS. And I think in the English system, the setting up of ICSs and hopefully their focus on population health will give another opportunity for the attention to be on where can we make a difference? How can we shift health outcomes that will really improve health inequalities and not widen them? And the last point I wanted to make, and I think it's particularly important that we try and do this in trying to focus on climate change as well, and how do we look for opportunities for a green recovery and make that part of our pandemic response. Next slide, please. Sorry, thank you. So how do we set about building an effective public health workforce and system? This, of course, is very important to us in our role at the Faculty of Public Health. As you know, we're a very broad church, we're a multidisciplinary specialty, and we have a great deal of interest, not just in the specialist end of public health, but all our practitioners that are working in public health. And there must be really a very good collaboration in a country the size of England and right across the UK, that we're focusing on local, regional and national public health workforces. And of course, all through this pandemic, I've been working very closely with the Association of Directors of Public Health and Directors of Public Health, and looking at the fantastic job that they've been doing in trying to support their local places and really delivering that close to where people live agenda. So there needs to be some way of not losing sight of this and making sure that the key 3 domains of public health are actually given the right amount of attention. So it's not just about focusing on health protection, important though that is. is really focusing on health improvement and healthcare, public health. And we must not lose sight of these important functions of public health. The picture in this slide shows the document that we presented as a Faculty of Public Health, showing all the domains of public health and all the functions of public health. And it is really important that in the restructuring of Public Health England, these important services aren't lost. And I would also make a really important plea that we try and invest in environmental health. The environmental health officers are very much part of the public health family, and I think they don't get enough attention and enough support. We've got a huge range of practitioners in public health, so I'm very keen that we're not just focusing on the specialist end of the workforce. And last but not least, I think we have an opportunity with the decision to set up a ministerial board. This came out as part of the public health reforms. I think it's a long time since we in this country have had a cross-government agenda on public health and health inequalities. And we're hoping that the ministerial board will really drive and look at the health outcomes for this country and actually try and use its influence on the other government departments and try and get the whole system working together to focus on doing the right things and getting the right interventions in place. Thank you. Next slide, please. And so, of course, you can't do all of this important work without having some of the right resources. Now, maybe we're not going to get every resource we need, but I think we have to recognise that playing a big part in the terrible situation we find ourselves in with health inequalities in the country has been years and years and years of austerity. When I led on health inequalities, we managed to narrow the gap in life expectancy and improve infant mortality. And then sadly, that important progress we made disappeared and the gap got wider. And as I said at the beginning, life expectancy is actually stalled. So we really just don't have the resources going into public health. So we continue to lobby for at least £1 million increase in public health funding. And I have lobbied also, I think another important message is that a lot of money is spent in the NHS. Wouldn't it be wonderful, absolutely lovely, if we could just get a little tiny bit of that resource? And so I'm lobbying for not even 1%, a point something of 1% of the ICS funding to go towards prevention, public health and health inequalities. Think what a huge difference that could make. And then we've got a big task as we go into these restructures to make sure that we get the whole of the public health workforce not fragmented. I think we can't ignore that some of the changes, well, maybe will bring good things, but actually a lot of it will fragment the public health system further. And whether you're a public health person that has public health in your name, or perhaps you're one of the thousands of people who have rallied around to help with the pandemic, even if you don't have public health in your name, we need all efforts of society working on public health. And your role is just as vital and just as important, wherever you are and whatever job you're doing that's supporting the public's health. I think it's important, the messages I've given hopefully will resonate with you. You'll see that they're all about how we improve the public's health, particularly those in the most deprived populations, and how we need to lobby more for the funding to come into public health. Thank you very much, Lord Patel. I'll hand back to you.
Thank you very much. And you've covered such an array of issues there. Some quite gloomy, but, you know, I think realistic and optimistic as well in places. I should say a number of people have said a thank you to you for mentioning the environmental health sector. I think it's often probably forgotten, and somebody said and they play a big part, particularly in the prison sector as well. So, you know, really important. People are glad of that. I'm just going to pick one or two questions before we sort of go to our next speakers. There's a couple of questions, and I'm trying to put them together about saying, we've got the new ICS, but they're very quiet on people like hospital governors or patient participation. Unless that wider public patient voice comes in, do you fear that's not going to happen?
Well, I think we've got to strive to try and get voices heard. I think that's a big part of our advocacy role. And I didn't want to be over gloomy, because I don't think you waste a crisis, do you? Before the pandemic, it was very difficult to get public health recognition. We'd almost forgotten all about little old public health, and now we're back centre stage. And I do mean everyone in public health, all aspects of public health. So I think we do have a real opportunity as voices are now amplified. But I think we've got to move quickly. Pace is very important. I've been through many pandemics before. I've been through many major incidents before, and we won't stay centre stage for long. A couple of weeks after and this won't probably be until next year, post-March, I suspect, when things quieten down with COVID-19, and if we don't have something else churning away as another pandemic, then it'll be over and people will forget about it. So I'd encourage us to have a really, really good agenda now and go for it with pace, because there's no one stopping us delivering these things. Yes, we'd like more resources, but I can remember days when we didn't have the resources we've got. We were still able to do, fortunately, most of the interventions for public health are either free or very cheap. So let's go for it and try and get this agenda really zinging along, and take the voices of people with us, particularly those that need us to amplify them.
I think there's one message everyone should take away, is that message you've just made. Every cloud has a silver lining, if you want to call it that, but there's a small window of opportunity for public health to really get on and stay on the agenda. And if together, as the public health world in its broader sense, including the Royal Society for Public, we get together and keep on this campaign, I think that's really important. So if people want to hashtag RSPH Sparks debates and say that, and let's get this huge community together and really push for it. I'm just going to ask you one sort of question that's popped up when you were speaking, because the place-based approach, and you were saying sometimes public health interventions widen health inequalities. If the funding wasn't there in the sort of levels we want, would you suggest that it's not just about more money, but it's about targeted on particular groups in particular areas, and we could use the funding better that way?
Yes, well, I think it's a twin track, if you don't mind me saying. I could name all the immunisation programmes, all the screening programmes, the free, aren't they at the point of delivery in this country? And where is the uptake? Where's the COVID uptake? Where's the flu uptake? It's in the most affluent populations. So where we have free resource and good programmes, we have to work to make sure that all those people who are in the greatest need get to the front of the queue and get those free resources. And then when we're investing new money, and this is where I really want us to work with the ICSs, who, I'm sure they'd like more money too, but compared to what we've got, they've got big spend, then working with them, looking at population needs, can we get them to invest first in areas of deprivation? And for the first time since really I was responsible for health inequalities at the department, I haven't heard the words that I'm hearing now from the NHS and other players, other government departments. And it's very unusual for central government to really say, we want to make a difference on health inequalities. Now, yes, they're only words, but sometimes we don't even get the words. But we need to now know what's the action. And we're the people with all the expertise. Everyone on this call today will have expertise. So we should all take responsibility for saying, right, what actions are we going to take that we can do either with the resources we've got or with that comes free. You know, we've got a huge voluntary sector out there, and the general public. I keep talking about not just the councils, but the town and parish councils. You know, the most active people in my village are the parish council. You know, they are fantastic. So I would like to take us in that direction, if I may, Lord Patel.
Yeah, no, that's really, I mean, that's a really positive note to end on. Like you say, we've come a long way, but we a long way to go. And I echo the work that parish councils do. I think we sort of sometimes forget how much they can do at a local level. Lots more questions, but we'll come back to you at the end, Maggie. I'm going to ask Richard Sloggett to take over now. Richard's the founder and program director of Future Health, which is a global healthcare policy research centre. I think Richard's going to share his views on how government should approach building a stronger, more resilient public health system post-COVID. So give us the answers, Richard.
I'll try, Lord Patel. Good afternoon. Thank you very much indeed. As a former special advisor to the Secretary of State on the Prevention Green Paper, I'm here to tackle the governance side of what governments should be looking at in regards to building a more resilient public health system. And this conversation is obviously very, very timely. It is, after all, 40 years since Sir Douglas Black, author of the Black Report, said achieving a high standard of health among all its people represents one of the highest of society's aspirations. Present social inequalities in health in a country with substantial resources like Britain are unacceptable and deserve so to be declared by every section of public opinion. And I think that statement from 40 years ago feels even more salient today after COVID-19. We know that COVID has had a devastating impact on our nation's health and has exposed those health inequalities that Maggie set out earlier. 90% of those who have died from COVID had significantly prior poor health. The most deprived places have had double the COVID mortality rate of the least deprived. We know what needs to be done to tackle this, but we struggled to deliver it. And today I want to explore why and what government should look to do about it. It was the great German philosopher Friedrich Hegel who said, the only thing we learn from history is that we learn nothing from history. We have an opportunity in 2021 as we move through and beyond this pandemic to learn something. The real question for government is, does it want to? The 2015 spending review, which saw NHS spending protected whilst other areas of public health, social care, capital investment and workforce cut back, was a major, major misjudgment. More money for the NHS is of course needed against rising demographic and societal trends. But when it is not complemented with adequate investment in those supportive areas that I've just described, it leads to stagnation and decline. This year, we face a real fork in the road for our healthcare policy. The government will announce a multi-year spending review, which will include public health, in the autumn of 2021. We can continue to choose our NHS first approach to health, or we can try something different and more transformational. The lack of voice on health in the 2021 budget was a worrying sign that this change will not happen. There will be money for NHS backlogs, some more cash to keep the social care system just about afloat, and a new organisation for health security and more pandemic testing. But the fundamentals of a properly funded public health grant and moves towards a prevention-led healthcare system will remain as unfulfilled goals. This will be a wasted chance for change. It will see health inequalities widen, and it will leave us exposed to future pandemics. And if we want to stand behind a phrase of building back better, it needs to mean a lot more. Overturning our NHS first orthodoxy for health is of course much easier said than done in a country which has had the NHS since 1948. A public-led healthcare system won't just happen. But as Maggie has set out, we need to use this window of opportunity to start to make the changes we want to see, to make a case for health improvement as part of our national renewal, and to confront those who advocate only piecemeal action or frankly total inaction. But to do this will require reaching out and building a new consensus. Recently, I undertook a piece of work for the All-Party Parliamentary Group for Longevity, a cross-party group of MPs and peers, setting out what this consensus could involve and where action could be undertaken. The report, which is called Levelling Up Health, which is on the APPG's website, sets out a new deal for public health that sees new investment and new action committed on priority public health areas, such as smoking, obesity, air quality, and healthy children. and is the need to build this new consensus for change that needs to happen next. And I've identified 5 enablers for change that I think government should focus on as it looks to build this more resilient system. The first of these is setting a new ambition. We need to set a new ambition about our nation's health. As Maggie stated, life expectancy has stalled in the last decade and inequalities have widened. The government needs to publish a new public health strategy or health improvement plan that sets out a path to increasing healthy life expectancy by 5 years by 2035. Now, it may surprise some people on this call, but that target of increasing healthy life expectancy by 5 years by 2035 is a government manifesto commitment. What may not surprise people is how far away from hitting the target we are. Research conducted by those at Future Health has found that on the pre-COVID trajectory, the post-2010 trajectory, we would not reach that milestone until 2050 for males and not until 2085 for females. Those numbers are unacceptable and need to be addressed. The second enabler is leadership. Public health does require strong political oversight and taking tough decisions. Just look at the progress we have made on smoking or air quality, where politicians have taken tough decisions. With the decision to decommission Public Health England, the Office for Health Promotion can now ensure that ministers have greater accountability over the public health system. But as Maggie also set out, this cannot just be a Department of Health and Social Care effort. The importance of the Chief Medical Officer, who I know kicked off this series from the Royal Society, and cross-government efforts are going to be absolutely critical here. The new Office for Health Promotion needs to have links to other departments through joint working relationships and secondments, and the new Cross-Government Prevention Board needs to have senior representative from each department and have clear ambitions around the strategy, which was the first enabler that I set out. The third that you can't get away from is resources and funding. And I think this needs to look at a number of different aspects. The first is we need to support and invest in the public health grants, and we need to ensure that there is a stable level of investment going in on a regular basis. Here at Future Health, we advocate a triple lock mechanism on the grant, which would see it tied to GDP, the NHS spending, or inflation, whichever is greatest, to give certainty to local public health directors and local leaders that they're going to get the investment in services that they desperately need. Alongside this, we think that there needs to be a greater role for the Treasury in public health. The Treasury should be assessing all of its major fiscal events, budgets, and spending reviews against commitments to improving the nation's health and well-being. We're seeing some really interesting things in places like Wales and New Zealand around governments that are putting well-being and health on an equal footing with GDP. And I think there's real merit in that. Lord Gus O'Donnell has said that this spending review should be categorised as a well-being spending review. He's former cabinet secretary. And I think that model has real merit and benefit. Finally, in regards to levelling up and investment, I think there's a real need to make sure that there is investment in areas which have been so badly affected by COVID-19. What we advocate here is the creation of a health improvement fund to channel new investment into areas that have been particularly badly affected to ensure that health improvement is a part of the levelling up agenda. There's a huge focus from government at the moment on infrastructure spending. What we want to see is investment in healthcare spending as well in regards to public health. 2 final enablers, the first of which is workforce and partnership. We've seen some amazing collaboration throughout the pandemic, and we've seen the real value and role that local authority public health leaders can demonstrate. And often there is a real disconnect between the insight from national government into the role and importance of local government. And I think one of the opportunities on the back of this pandemic is to close that gap and to really make sure that that value is properly recognised and those voices are properly listened to. And again, I think there's a really important role here for the Chief Medical Officer in the new Office for Health Promotion. Maggie also mentioned the creation of NHS ICSs, and local government and local authorities need to have a really important role on those. And there's obviously, we still need to see the detail about what is in the health bill, but a clear role for local government in feeding in and ensuring that those ICSs deliver on their prevention mandates is obviously critical. And finally, there is an opportunity with data, measurement and technology. We see the Office for Health Promotion as having an opportunity to work with local authority public health leaders to drive improvement right across the system. New technology presenting opportunities to collect better data on health outcomes and to drive more targeted and improved investment and policy decisions, and new frameworks and mechanisms that can measure health and well-being effectively And I know that Johnny Pearson-Stuttard is talking after me about the Office for National Statistics' health index as one opportunity to do that. So 5 enablers there that I think, from a government perspective, if they were tackled and addressed, could really help us build that better public health system. But 2021 and that multi-year spending review this autumn, it's critical that the public health community stands up and pushes very hard to get the right settlement in order to deliver on that mandate. With that, I will pause and hand back to you, Lord Patel. Thank you.
Well, Richard, how do we get you back advising government, I suppose, is the first question. Because, yeah, I mean, you sort of described the sort of 5 enablers there, and they just seem sensible, but knowing governments, as we all do, you know, sensible sometimes doesn't quite get you there. But I mean, you know, really, really important. And I would recommend Levelling Up Health for everyone to read. I think, you know, excellent document. And the idea that we're so far away from just giving people 5 years more life expectancy is just mind-boggling. I mean, you know, it's a longer-term vision we need to look at. Right at the end, you talked a little bit about technology and data, and data is quite crucially important. Population health management is crucially important. Just in terms of a controversial thing, you know, we've suddenly, I would imagine, in the last 6 months, we've used more technology in the NHS and places than we have done in the last 10 years, in the next 10 years. Do you think the sort of advances with telemedicine and, you know, and the sort of, you know, patient care through technology is going to change the idea that the patient-centered care is really all important? And we're not going
So I think this is often discussed, and I agree with you that we've seen significant leaps forward in terms of how technology is used, and some of it is just basic technology. It's just using the telephone for consultation rather than a face-to-face. I think you need to move to a model that works though for the user and the people you're trying to target. Technology is not going to work for everybody, and it needs to be an enabler for the best outcome. So it shouldn't be a substitute for delivery. You need to look at what the impact you're trying to achieve is, and is technology going to be part of that solution or not? So it's being able to tailor the model. So for some audiences and some groups, technology will work unbelievably well and actually might be the absolutely best way to get them through the system. For others, it absolutely will not be. So I think it's very much here to stay, but what we need is a properly measured and tailored model, which is based on evidence rather than anything that's particularly top-down or gimmicky.
Yeah. And how do we, you know, in preparation for any future pandemics, how do we sort of, you know, now get that third sector, other public services involved in this and preparing for the future? How can we make them more resilient? Again, is that funding or?
So I think there's a couple of interesting bits of this. One is really positive, which is we've seen an unbelievable response from volunteers and the public to support the system in and around this pandemic. Anyone who's gone through that vaccination system will see that. But it's much wider than that. It's a real role for people in their communities, and that, again, that importance of the local in all of this is really, really critical. But one thing we haven't necessarily done in this country, in the way our healthcare system is structured, is we haven't built in any slack or surge capacity. And I think this is a public conversation that we're not having, which we need to have. If you go to every country is different and there are positives and negatives of each system. But if you go somewhere like Singapore, where they have got a specialist hospital which deals with infectious diseases and it is completely wired up to look at and train and educate, we do not have a spare facility sitting there quietly. If we did have, we would probably have headlines in certain newspapers saying, why are we wasting money on white elephants? So, but we do need to have this conversation. We're still in the foothills of what the post-pandemic health impact is going to be by closing down certain services or restricting access to services, and care was continued in cases, but it was not in others. We are going to come out of this with a range of different population health challenges, and what we can't have is we have another shock that's only going to get worse. So how we design and build in that surge capacity or that slack and that is going to involve some level of resourcing, is a conversation that we do desperately, I think, need to have. Really,
really interesting. And please, people, keep looking at the chat function, because Lots of very interesting comments, and people would like a link to your report. So
I'll dig that out.
Building Up Health, so that'll be there. I'll be back to you again near the end, Richard. I'm going to move across to our final speaker now, Dr. Jonathan Pearson-Stuttard, or Johnny, as we like to call him. John is a public health physician and epidemiologist at Imperial College London, but more importantly, he's the Vice Chair of the Royal Society for Public Health. And I think you're going to carry on this theme to explore the inequalities across the stock of health, as evidenced by the first health index, Johnny. Over to you.
Thank you very much, Lord Patel. I'm just sharing my screen now, and hopefully you can see my slides. So thanks again. You can see my slides okay, Lord Patel?
Yes, absolutely.
Great.
Yeah.
Thanks, and thanks to Richard and Maggie too for setting such a. It's difficult going third sometimes when you've already such compelling cases have been made around health inequalities. I first just wanted to start by just reminding of some quite harsh statistics before the pandemic even hit, and we all know that the pandemic has both concentrated and highlighted the health inequalities that were already existing. So here, this is some work from our group at Imperial. You can see female life expectancy across deprivation deciles. So in the blue at the top are the most affluent 10%, the red at the bottom, the most deprived 10%. And so you can see in 2001, that gap across England and Wales, most and least deprived 10% was 6 years. Fast forward to 2016, that had increased to 8 years. Now, everything we know about the pandemic, and as Richard mentioned there, twice the mortality rate from COVID-19 in the more deprived 10%, it's very likely that this gap has got larger. When we look at that as well, we often hear about averages and that generally life expectancy is slowing in the UK, still increasing at the aggregate, but very, very small amounts. But that's not true for everybody. And particularly the most deprived 20% of women have actually seen their life expectancy go backwards since 2011. Again, this is all before the pandemic has hit. When we look even more at smaller groups, for example, at local areas, the gap can be as much as 20 years in life expectancy. But that's when we're talking about illness. And of course, so much about levelling up health is about what health we see as an opportunity to work, to enjoy life and to be happy. So when we look at health, rather than inequalities just in illness, then we see that actually the gap's even bigger. So this is data from the ONS, the gap in healthy life expectancy. Again, at the top of each bar, we've got the most affluent, women at the top, men at the bottom, down to the most deprived at the bottom in the red. And you can see in men and women, you're talking around 18 and 19 years gap, 18 or 19 years fewer years lived in good health in the most deprived communities compared to the most affluent. And given we know again how this is borne out over the pandemic. Now, part of the problem we often find with health inequalities is that we all know in public health and health generally, that actually it's the drivers or determinants of health, as Michael Marmot and others have laid out, that they're the biggest drivers of inequalities and also the biggest drivers of ill health. People living in ill health for longer, that affects their ability to work, prosperity and happiness and so forth. And too often in health, nationally, we focus on health just as that illness measure. So if we see it's in a book Sally Davis and I wrote last year, we spoke about health being an opportunity, in fact, our most untapped opportunity for prosperity, for happiness, but also for leveling up. But those opportunities of health are very unequal. And that's not just because health outcomes are equal, it's all of these determinants too. So in 2018, Sally Davis, in a report I edited, recommended the development of a new composite health index. The idea with the health index was most measures we have nationally tend to measure illness, life expectancy, cancer survival, and so forth. Whereas we see health as an asset to each of us as individuals in terms of to work, live and play, but also, of course, to our economy. And over the last 18 months, we've seen that those nations across the world that have had the poorest outcomes from COVID-19 have also had the worst impact on their economies. So the Cabinet Secretary commissioned the Office for National Statistics to develop this health index, and the beta version was published in December, with the full version coming later in the summer. And the idea of the health index is to capture the nation's stock of health. And this doesn't just measure illness, but measures our health and the drivers of health. So there are 3 layers to the health index, and importantly, each of these 3 layers are equally weighted. The first is healthy people. That captures some of our traditional health outcomes: healthy life expectancy, cancer survival, heart disease and survival, and so forth. Healthy lives, which we might think as risk factors, and many of those social determinants, like smoking rates, obesity, and education. And then healthy places, green space and access to green space, levels of crime, distances, and access to services. All 3 of these making the stock of our nation's health, knowing that improving that stock will improve economic outcomes in the future. When the ONS has published this, you can see here that this is looking at that healthy people domain. Each domain has subdomains and then around 62 indicators. And this is just to show over this 4-year period just how different the trends are in different domains. And we can mask this when we just look at life expectancy or just look at healthy life expectancy. You can see that whilst self-reported well-being increased over the period, physical and mental health conditions really declined quite a lot, whilst mortality was pretty stable. Again, life expectancy, we know, has been increasing at a much slower rate, but actually it's that lived experience of health, morbidity, physical and mental health morbidity, that has been so much worse off. But what we then did was we also then wanted to make this a little bit more interactive. So this is the Health Index Explorer here. And what you can see on your screen is a map of England. The initial index was just for England and will be expanded to the devolved nations in coming months. But you can see this is the health index for each upper tier local authority in 2018. Again, the version this year will have data right up till 2020. Those areas that are in green have higher than the national average, which was set at 100 as the index, and those areas in orange or red or lower than the national average. So you can see the geography here and how that stock of health varies across the country. But what it also lets you do, and we'll give an example, and I'll pick where I was born and grew up in the northeast, up in Northumberland. So first of all, we can see Northumberland, it's ranked 107 out of 149 upper tier local authorities. And you can see actually it's better than the England average on healthy places, good access to green space, lower crime rates, etc. The healthy lives, those risk factors are a bit below 100, a bit worse than the national average, but really quite poor on some of the health outcomes. So what we can do then is compare actually this either with the England average, each one of these representing a specific indicator. So for example, physical health conditions are quite a bit below the national average, and we can see as that respiratory conditions, musculoskeletal, dementia, and explore each of these. Again, an area in green, meaning that it's better than the national average, an area in orange or red that it's worse than national average. And you compare, for example, within the region, where does it do better than other areas within the Northeast against and those that it does better. And again, the idea of this is to say we too often just measure health outcomes and the inequalities in these, but this identifies many of those social determinants that Michael Marmot and others identified. We can see exactly which communities have better or worse specific domains, and where might we be smartest to invest our money, not just to level up health, but knowing that leveling up health will also level up the economy. And finally, I just want to finish on this screen here, where we can plot our own graph. So here we've got the health index score, so how healthy that overall stock of health for every local authority on the y-axis here. On the x-axis is the deprivation score. More deprived in this bottom right, least deprived here, less healthy here, more healthy here. And you can see this really depressing correlation. The more deprived the community, the lower their stock of health. With Blackpool here with a health index of just 86.4 compared to Wokingham. And as I say, you can then tease down why. Is it health outcomes? Is it the risk factors, other wider drivers? And where might we invest for our biggest bang for our buck? And for perhaps, when we look at the healthy people layer, you can see there is some correlation still there, but not quite as strong. But clearly the NHS too has its role to play. But if we look at healthy lives, and so much of this is around risk factors and the structural environment that we live in. And we know, for example, whether it's fast food outlets are more dense in more deprived areas, through to smoking rates and smoking in pregnancy. But just look how striking that is. When we're looking at healthy lives, these risk factors, the more deprived your community, the much lower your healthy life score. And if we're looking for areas to invest, not just to level up health, but to level up local economies and social mobility, we can't go much further than looking at the structure environment around us. So thank you very much for that, and over to you, Lord Patel.
I'm still absorbing everything you said. I thought that was, and I'm echoing what people are saying. That was fantastic and phenomenally helpful. When is this going to be sort of available to local authorities, districts, and people who can start using this?
Well, thanks very much. So at the moment, so the ONS have taken all of the consultation on board, and the full version of the National Health Index for England initially will be developed will be launched later this year. And it will be within 6 months of the data. So we're not looking 2 years back, it's relatively recent. The ONS are also looking to develop further, actually to take this further to devolved nations, but also across the OECD. Now, of course, the user, if you like, in this instance has been national, which is why the unit of geography is just at local authority level. So that's good for national resources because we're looking at 150 different areas. But within a local authority, we all know that within 350,000 people, there's such differences in health and health drivers. So the next challenge, and something we've just started, we're in the process of starting up in Northumbria, is actually to develop this much more locally. So to take Northumberland and North Tyneside and actually to go down to hopefully MSOA or even LSOA levels. So you can look how these health outcomes, the drivers of health and so forth, vary across very small groups of people. And that way it can inform locally how we can target health inequalities most. But most importantly, this is just an initial idea. The national one will be published in a couple of months, but we want everyone involved. Tell us and tell the ONS what you think. How can we use it more and make it as useful as possible to level up health going forward? And that will you overlay ethnicity, gender, sort of age groups? So we know it's the African population in a particular area. Absolutely. So at the moment, we've added that index multiple deprivation as a measure, so we can see how each part of the index varies according to that. And as you know, that's just a postcode measure itself, a sort of composite measure. What we need to do is much more granular, both in terms of sex, in terms of ethnicity, and in terms of all types of variations that we know that either the experience of health or how health outcomes vary by. Part of that is a data challenge, in that we tend to find, part of the difficulty is that many data sets don't have, for example, ethnicity data in there. And that's something that this also highlights the need for capturing really important data like that. One thing that the pandemic has shown is that, A, that inequalities are so persistent throughout society, but B, they're very different for different people. And it isn't just about your postcode, it isn't just about your ethnicity, it isn't just about your age. And that we have enough data now to be smart about how we invest and smart about how we try to level up, to make prevention much more personal than the sort of one-size-fits-all approach that we've used in the past.
The three of you, Maggie, Richard, and you, Johnny, you sort of almost put a jigsaw piece together, actually, because, and I'm paraphrasing, life was bad before the pandemic. It certainly shone a big light on lots of things, and it's got really bad. But we have the potential now, by being, not clever, by using data like this, by targeting places, by, really positioning prevention at the front, a huge opportunity to go forward. I think that's really come together well. So many questions, so many things there. I'm going to sort of ask a big one and to all of you, in a sense, sort of balancing some of the questions together. It's a bit future focused. How does a public health system in the future balance addressing both the immediate threat from things like COVID-19, future pandemics, with what you talked about, the persistent long-term threats through systemic inequalities, lifestyles, risks, determinants of health, as you call them? Who fancies that one first? How do you balance this? Johnny? Yeah.
Go on then. I'll start, and then Maggie and Richard could say something much more thoughtful. I think part of it comes back to both Maggie and Richard's point about resilience, though, is that so when we looked at excess deaths, for example, and how the UK fared compared to other countries, we tried to be more constructive about why that might have been. Now, clearly policy was really important. locking down at the right time, test and trace being able to continue. But it was also about what was the health of the population and the health of the health system when the pandemic hit. And that's about resilience. And so part of that, again, is, as you say, we've got these long-term issues, and then we'll always have acute events. And people like Maggie are extremely used to having dozens of acute events every normal winter, just they aren't on BBC 24 hours a day. This is the day-to-day work, of across public health generally. And so I think it's that resilience to be able to capture and really build on these ingrained challenges that we've got, but enough resilience to cope with acute shocks without derailing that work. Indirect effects we'll see of the pandemic, delays to cancer care and so forth, but to do the two simultaneously. And that requires reprioritizing how we look at health and how we fund public health particularly.
Yeah, good point. Richard, do you fancy having a dab?
I just had to try and get myself off mute. So no, I completely concur with Johnny in that you've got to run this as a twin track. I think there is a real danger from the government lens that it starts to see health security and pandemics as so important that it diverts much more attention into that new UK Health Security Agency that it's created and spun out of public health thing, and that the health improvement thing, which is so important and creates that underlying resilience, is less of a priority. It comes back to, yes, resources, but also how you structure something as a cross-government working entity, so you get the different bits of government working much more closely and much more collaboratively. Now, cross-government boards sound great in theory. They have got a very, very mixed track record of delivery, because you have different departments have different ambitions and priorities, and sometimes they actually rub up against each other. I remember we tried to get a piece of work through, policy work on health and work, which is such an important agenda. We spend so many of our hours a day at work. There's a great enabler. It could be a great enabler for better or worse health. But when you're working with the Department for Work and Pensions, who have one set of incentives, and you've got the business department who basically won't put any extra regulation on health, and then you've got the Treasury, which is looking at, you've got a series of misaligned incentives. So if you're going to get that prevention board to work, you've got to be really clear about what it's going to deliver. You've got to have really strong central leadership. I think the CMO is a great person to start to lead that, but it's got to be led out of number 10 with the Office for Health Promotion providing that input. So yeah, this comes back to that leadership point. It's you've got to see that central leadership to kind of harness the different bits of government in the right way. It's complicated, but it needs to be done.
Really important points made there. Really important. Maggie, just using Johnny's original sort of map thing. That'd be ideal for parish councils probably to really drill down. And sorry, we keep saying you've been through millions of these pandemics as if you've been around forever. Would you like to add to anything that Johnny and Richard said?
Yes, I'm delighted to. And yes, I have been around a long time, and I have been through many pandemics and many emergency incidents. I think what's been different about this is, well, this is unprecedented, and we always sit there and say, when in public health, not if we have a pandemic, but when are we going to have a pandemic? And I think we'd be very foolish not to have our eye on the, we still look at the what's happening around the world. We look at the south and see, how's their flu taking off, because they get that before we do, avian flu and all manner of things. But I think the point I'd like to make is it doesn't have to be either or. That's one of the great problems that people make, being too pedantic in public health. People need us not to be arguing with each other and being pedantic about who's right and who's wrong. If we'd approach this pandemic, and I'm not a political person, so I'm not making political comments here, but where was all the experience? The experience was mostly outside government. And I think we had a perfectly good civil contingency system in the UK. We have COBRA, we have LRFs, and I think they were pretty much bypassed most of the time. And instead of jumping at the centre, you know, people make the mistake. When I was delivering on health inequalities, I connected out because I had the wisdom to realise and convince ministers that we wouldn't deliver at the centre. You never deliver at the centre. It may give you a sense of control that you can pull a few levers, but delivery happens locally, and the more local you are, the better. And as we know, you can't wave a magic wand and change behaviours. You have to take the people with you. And instead of doing either or and being totally pedantic and top down, we could have invested billions into local communities. And where did the billions go? In centrally driven central contracts. And actually, I don't think they were as effective. And I remember I don't spend all my time moaning, Lord Patel, I just want you to know that. I do go in and help at some of these groups. And I was sitting at one of these groups on testing design, and someone who was very senior was trying to talk to me about the contracts with the private sector and how well they were working and customer focused, and they'll get it right next time and then they'll revise and it'll be perfect. I said, you could spend 30 years revising that contract. And I know you're working hard, I know you're very dedicated, but it would take you at least 30 years to know what I know about my local community, or what local councillors know about the local community, or any local professional knows about the local community or voluntary sector. So you've got the wrong model. And so we could have invested billions in some of those. Where's the infection highest? Well, this is nothing new. Those areas were written about in the 1800s, those areas for the country, about poverty. And where are we now? They're still the areas with highest transmission and transmission that's hardest to change. So there's nothing new here.
No, absolutely right, Maggie. And we've continued to say place-based approaches. Bottom-up approach to tackling health inequalities. It's the local people that deliver. One final question to all of you, and I shall read it out. How should the Office for Health Promotion function, and who should it recruit? Who's going to start with that one? Richard, how about a political answer to that one? So how should the Office for Health Promotion function, and who should it recruit besides yourself?
So I'm more on the optimistic side of the Office of Health Promotion for a couple of reasons. So one is, I think there is no excuse for ministers through this new office to try and dodge the public health challenge that we face. I think this function will be closer to ministers, and therefore they need to take greater responsibility and accountability for it. And we haven't talked about the 2012 reforms, but I think the 2012 reforms are also a mechanism for creating uncertainty and a lack of resilience in our system. So I do think this, and I think that again, that CMO is independent, and that you get that independence and you get that ministerial oversight. If you can get that model to work, I think it'd be really important. I think who should it recruit? And I think this comes back to Maggie's point. This pandemic has exposed a number of things, but what it's also really exposed is the chasm that has opened up between national government and local delivery. And we don't have a particularly good track record in this country of making that work. But there are other countries where they have more federal systems, more regional systems, where that model is more just ingrained. We haven't really done that. Again, I'm hopeful through the health bill and the creation of integrated care systems, you've got to get the place-based element of that right, and that is very much to be seen. There is an opportunity in that, but I think the Office of Health Promotion needs to have an objective of closing that gap. It can't just be a national body that does national stuff and then just tries to cascade it down. It's got to have a network-style model where you get that level of flow back and engagement and intelligence about what's working and how things work. So I think that there's a couple of, and I think to do that, you're going to have to recruit people who understand how local public health is effectively delivered, and you're going to have to build bridges and relationships through that. So there's a couple of reflections on me as the government sets that up.
Really, really helpful reflections there, Richard. Johnny, and you'd obviously say your new map data would be crucial to it, wouldn't it?
Well, I think definitely what we have in the health index now is a way of measuring and incentivizing investment in upstream prevention. So the challenges previously, if we put lots of money and very sensible approaches today into things like childhood obesity, we won't see the full effects tomorrow. We might not even see them in this government's term. And so they want to be re-elected in 3 years' time. However, if they invest in prevention, healthy places or healthy lives domain, the health index will go up. So they can stand at the next election and say GDP went up, unemployment went down, and our health index, our stock of health went up. So definitely, I think that should be absolutely a measure for the Office for Health Promotion. In terms of who, I think, as we've all said, and Maggie summed up perfectly around the perfect being the enemy of the good. We don't want this to be owned only by health people. We've been speaking to health people all the time. To make this work, we need everyone to agree that actually health promotion, levelling up health, is good for everybody. Good for everyone in government, but also good for the nation. And so I think as broader a coalition is important in succeeding for the Office for Health Promotion.
Fantastic. Maggie, last 20 seconds to you, because you absolutely deserve it.
Well, yes, and I'm sure we will come back to this, because it is a great pleasure to work with you, Lord Patel and Christina, and the excellent work you do as RSPH. And we will need a group into the future. I think our current groups need to be refreshed. We'll need a group to hold government to account. But I am quite attracted to the idea of the Office of Health Promotion, because if you look at how the department is at the moment, I think Chris Whitty's basically got 6 people working for him to do everything. So is it any wonder we haven't got the right policies and everything else? So I think we will do better. When I look at the devolved nations, I think they've got better policies than England has. And I hope to see this as better policies for England. And we just have to hope that they don't. We've got to make sure there's independence and not too politically driven. Thank you.
Fantastic. And that's where we leave it, that we're going to set up some kind of group that's going to keep this momentum and story going, and where we can have an impact. I can't thank you all enough. It's been absolutely fascinating. Thank you for all the people who've listened in, and stay safe. And I look forward to seeing you in person in the very, very near future. Thank you all very much.
And big thank you to Richard and Johnny too. Thank you, colleagues. Thank you.
Thanks, everyone.
And the audience, great audience. Thank you.
Take care.